welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Thank you, everyone, for joining the February ACCP EMED PRN Journal Club. Today, we have Paige Hanke, who is a PGY2 EM resident at Detroit Receiving Hospital. She will be presenting a journal club on Olanzapine versus Haloperidol for management of acute agitation in the emergency department, an open-label randomized controlled trial. Thank you.
Hello, everyone. Thank you for that introduction. Today, I'll be presenting the trial he was listed above. My name is Paige Hanke, a PGY2 at Detroit Receiving Hospital in Detroit, Michigan. I just wanted to start off with a disclosure. I have no potential conflicts of interest related to the context of this presentation. Acute agitation is a common presentation in the emergency department, with up to 18% of ED healthcare workers experiencing workplace violence. Agitation is an extreme form of arousal that is associated with increased verbal and motor activity. The etiology can vary widely, including medical, psychiatric substance use, or toxicology, or undifferentiated causes. And in the emergency department, the cause of acute agitation can be hard to determine, as little is known about the patient on a presentation. Initial verbal de-escalation is recommended and should be attempted. But with moderate to severe agitation, chemical restraints in the form of parenteral pharmacotherapy agents may be required. And therefore, it's important to choose a pharmacological agent that has a quick onset of sedation and favorable side effect profile. According to the American College of Emergency Physician 2024 guidelines on emergency department patients presenting with severe agitation, they actually do make a level B recommendation for the utilization of both antipsychotics and benzodiazepine, whether that be as monotherapy or in combination. And they make a level C recommendation for ketamine. This presentation will focus solely on the antipsychotic portion and their different classes, and hopes to find an effective and safe monotherapy agent. For our typicals or our first generation antipsychotics, I've listed on the right side here the common typical antipsychotics, but I highlighted that we will mostly be focusing on haloperidol, as this is what the trial looked into. So halo comes in multiple forms. In acute agitation, we mostly focus on the IM or IV options. For mechanism, it is a competitive D2 or dopamine 2 receptor antagonist with some anticholinergic and some antihistamine effects. This is basically where the adverse effects come in. So with haloperidol, we commonly associate this with the extrapyramidal symptoms or the QT prolongation. For IM administration, the pharmacokinetics, it has a quick onset of about 15 minutes with a half-life of 20 minutes, a duration of about 120 minutes, with high protein binding, hepatic metabolism, and urinary excretion. And the cost is actually pretty cheap for this. For a 5 milligram vial, which is the usual dose, you will see it's around $1 to $7 per vial, depending on where you are in the United States. As for our atypical second generation antipsychotics, on the right here, I've also listed some common agents, but again, I'll be focusing mostly on olanzapine, as our trial has mostly focused on this. For dosage forms, we can utilize it as IM, sublingual, or even IV, even though it's not FDA approved in some studies. That's a whole topic in of itself. But for the mechanism, it's a weak dopamine 2 receptor antagonist and a strong serotonin receptor antagonist. And so with this, you're going to have a reduction in those extrapyramidal symptoms, but you will have a potential increase in the long-term effects if you continue to utilize the medication with weight gain and metabolic effects. As for the IM administration pharmacokinetics, has a similar onset as our last agent, around 15 minutes, with a half-life of 30 hours, a duration of 120 minutes, high protein binding, hepatic metabolism, and urinary excretion. I did want to put this here, as in many trials, the altered mental status or the AMS score is commonly utilized. It ranges from a +4, which is like the most agitation a patient can have, to -4, which is the most sedated a patient can be. And it is a validated tool that is utilized. Looking a little bit deeper into the background literature of the subject, a study by Klein and colleagues in 2018 looked at intramuscular midazolam, olanzapine, zerapidone, and haloperidol for the treatment of acute agitation in the emergency department. This was a prospective observational study that looked at about 737 patients that had a median age of 40 years old, and about 72% were men. Majority of these patients were actually psychiatric patients. It's important to note for later in the presentation. For the intervention, the doses are listed here, and the outcome was looking at the proportion of patients that were adequately sedated at 15 minutes. Again, this was assessed with that altered mental status scale. As you can see, at 15 minutes, midazolam had the highest rate of sedation, adequate sedation at 71%. And our agents that we will be looking further into our study, haloperidol at 5 milligrams had about 40% adequate sedation, and olanzapine 10 milligrams had about 61%. And so this study showed that for adequate sedation, olanzapine did have a better outcome, but neither of these were statistically significant. As for the adverse effects, both were pretty uncommon and similar among groups, with the most common adverse effect being, no cardiac arrests and low extrapyramidal symptoms. Another study that looked at intramuscular midazolam, olanzapine, or haloperidol for the management of acute agitation. This was a randomized double-blind controlled trial that was published in 2021. And this looked at 6 Hong Kong emergency departments with patients in a large range of age with undifferentiated acute agitation, which required parenteral sedation. So a lot more closely related to the study that we'll be looking at, but it did include a benzo group as well. For the outcome, the primary outcome was time to adequate sedation. They again used the altered mental status score. They define this as an altered mental status of less than 1. So this would be patients that are still slightly agitated. For the results, the median time to sedation in the midazolam group was 8.5, so it was better in the midazolam group compared to the antipsychotic groups. In the olanzapine group, we had 11.5 minutes. In the haldol group, we had 23. So it was about half the time with the olanzapine group to adequate sedation. And then at 60 minutes, pretty much all of the groups were very similar in the sense that around 90% of them were actually adequately sedated. For adverse events, they were also similar among groups, similar to the last study, and haldol was associated with the most common adverse effects. And so this study was helpful. Both of these studies were helpful. The type of agitation, so in the first study, we had patients who had mostly psychiatric backgrounds, and with this study, we had mostly patients with an altered mental status of less than 1, meaning that they were still slightly agitated. There was still some room to have another study that purely looked at the intramuscular administration of the 2 different classes of antipsychotics as monotherapy. And so we have the study, the olanzapine versus haloperidol for the management of acute agitation in the emergency department by Charity and colleagues in late 2024. For the study design, it was a prospective, open-label, randomized control trial that took place in North India. It was conducted from February 2021 through October 2022, and it was based in a tertiary care teaching hospital emergency department. For the study population, the inclusion criteria included patients who were 18 years or older, who presented to the emergency department with acute agitation, which was described as having an altered mental status score of greater than 3. So that means that the patients were about moderate to severely agitated. For exclusion, the patients that were older than 65 years old, pregnant or breastfeeding, if they had a known hypersensitivity to one of the agents, if they already had extrapyramidal symptoms or Parkinsonism, if they had alcohol withdrawal, pre-existing cardiovascular illness, so that included if they've already had a prolonged QTC, pre-existing respiratory illness, a cerebral vascular accident or intracranial lesions, or seizure disorders. For their methods, they used a mixed block randomization to receive the patients to receive either olanzapine IM 10 milligrams, or group B, the IM Haldol 5 milligrams. Physicians were actually unblinded to both the treatment and the outcome, and the altered mental status score of patients in both groups were monitored at 5-minute intervals for 30 minutes. Adequate sedation was defined as an altered mental status score of 0 or less. So this is different than that previous study that was mentioned before in our emergency room agitated patients. Patients adequately sedated at the end of 30 minutes were then still followed up for 48 hours to look for adverse events. The treating physician also indicated their assessment of the cause of agitation. So again, this includes psychiatric, medical causes, intoxication, or undifferentiated causes. For the primary outcome, adequate sedation in each group at 15 minutes post-antipsychotic dose was evaluated. As for secondary outcomes, adequate sedation at 30 minutes post-antipsychotic dose, the need for any rescue medications, and adverse events such as intubation, hypotension, QTC prolongation, seizures, or extrapyramidal symptoms were evaluated. For their statistical analysis, their baseline characteristic and outcomes for continuous data, they used the Shapiro-Wilkins test and Mann-Whitney-U. For dichotomous data, they used the frequency distributions and chi-square tests. And they did use a two-sided p-value, which meaning that less than 0.05 was considered statistically significant. And then the proportion of patients that were adequately sedated by time was plotted on a Kaplan-Meier curve, and then the log rank test was utilized to investigate the difference between the groups. So 254 patients were screened and 162 were excluded. 100 of them did not receive a chemical restraint, 39 did not meet the inclusion criteria, 8 declined dissent, and 15 met at least one exclusion criteria. And then included were 94 patients with equal 47 patients in each group. For the results of this study, the baseline characteristics were very similar among the groups, around 30 years old with majority being male, so 50 to 60% male. For their baseline altered mental status score, most of them were actually in the moderate severity of agitation, so baseline score of 3, and 78% of patients in the Olanzapine group and 87% in the Haloperidol group. And then they also determined the cause of agitation, so there was a spread of patients amongst all the groups. But in the Olanzapine group, the most common was psychiatric disorder, and in the Haldol group, the most common was medical disorders. But there was no statistical significance between the groups. As for our primary outcome of adequate sedation, 15 minutes post-antipsychotic medication dose, you can see that 31% of the patients in the Olanzapine group had adequate sedation versus 25.5% in the Haloperidol group. And although this is clinically significant, you can see here that the p-value is 0.213, meaning that it is not statistically significant. As for the summary of the secondary outcomes, sedation at 30 minutes was still greater in the Olanzapine group, about 61% of patients, and around 50% in the Haloperidol group. For median time to adequate sedation, it was about 15 minutes for the Olanzapine group versus 5 extra minutes, so 20 minutes in the Haloperidol group, which you can see here on the right on the Kaplan-Meier curve, the blue line being the Olanzapine arm. But this was not statistically significant with a p-value of 0.222. And then the need for rescue administrations were actually about double in the Haloperidol group. But again, this was not statistically significant. As for the safety outcomes, adverse events were low in both groups, with only about 4% in the Olanzapine group, but about double in the Haloperidol group of 10.6%. The most common cause of adverse effects in the Haloperidol group was the QT prolongation and need for intubation. Again, there was no statistical difference between the groups. The study did produce a subgroup analysis of the cause of agitation, and so they looked at psychiatric versus non-psychiatric subgroups. And as you can see in the non-psychiatric subgroup, the Olanzapine did have a greater reduction in agitation at both 15 and 30 minutes. But in the psychiatric subgroup, you can see that the Haloperidol had a higher percentage compared to the non-psychiatric group in reduction in agitation. potentially meaning that this medication could be utilized in higher amounts in the psychiatric patient population, with none of these being statistically significant. In conclusion, the author states, in our study, though intramuscular olanzapine performed better than intramuscular haloperidol in the management of acute agitation in the emergency department, the difference was not statistically significant. And they stated that there is a need for a more robust, multi-centered randomized controlled trial with a larger sample size to determine the superior antipsychotic agent in this patient population. Overall, for the strengths of the study, they did look at patients with both moderate and severe agitation. So anyone with an altered mental status score of greater than 3 was included, which I believe is a strength, as this is very common in the emergency department. They did do a subgroup analysis, which was helpful in determining when one agent might be better than the other. So we did note that haloperidol may work better in our patients with psychiatric disorders. They did use the clinically relevant outcome of adequate sedation using the altered mental status score, which is very commonly used among other literature. And adverse events were well defined and followed for 48 hours in order to ensure that they caught all forms of adverse events. As for limitations, this was a small sample size compared to the study that they referenced in order to obtain their power analysis. And so this study did not meet power in order to determine these specific outcomes. It did take place in an outside institution outside of the United States, but the agents that were utilized, both the IM 10 milligrams of olanzapine and IM 5 milligrams of haloperidol, is a very common regimen and actually could be very much associated with what we utilize in the United States. The investigators were not blinded to either the treatment or the outcome, which can lead to bias. And patient follow-up was only for 30 minutes for adequate sedation, which may be helpful in the acute setting, but in order to stop the reoccurrence of agitation, knowing a little bit more about long-term sedation could be helpful. So the key takeaways from this: IM olanzapine monotherapy has been shown in this study and prior studies to have a quicker onset of adequate sedation compared to IM haloperidol. Although haloperidol has been reported to have higher frequencies in general of QT prolongation and extrapyramidal symptoms, this may not be true when utilized as IM agents in one-time doses that we have seen in acute agitation, as both groups had low numbers of adverse effects. Agitation cause, I believe, is a very important factor for determining an appropriate treatment, and the subgroup analysis helped determine that maybe haloperidol works best in those with psychiatric agitation, while undifferentiated agitation may benefit, patients may benefit more from olanzapine. This study should be subject more closely in future studies. And although there are issues with just informed consent, which may make it hard to include patients in agitation treatment studies, a large double-blinded randomized controlled trial examining both IM or even IV routes of these antipsychotic classes may be helpful to determining a superior agent in the emergency department. And with that, that's the end of my presentation, and I'm open for any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.